Our first speaker today is Professor Dato Dr. Andrew Mohanraj. Dr. Mohanraj served the Ministry of Health in Malaysia for 12 years before taking up a range of international assignments. As a consultant psychiatrist and mental health development advisor, he accomplished pioneering work in the establishment of sustainable psychosocial rehabilitation services. On his return, he continued his consultancy work for both government and non-government organizations. He also served 2 terms as a member of the Mental Health Promotion Advisory Council to the Minister of Health in Malaysia. He's now taken up an academic position as adjunct professor of psychiatry at Taylor's University Medical School, and as an animal lover and advocate for animal rights, he's recently assumed the post of president of the Society for the Prevention of Cruelty to Animals in Malaysia. Beginning July 2021, Dr. Mohanraj has taken up a consultancy with the World Health Organization Regional Office as mental health and substance abuse consultant. His talk today is titled, "The Rising Risk of Suicide in the New Normal." His abstract for the talk reads, "After months of lockdowns and quarantines, there is increasing concern about the rise in depression and suicide across all age groups. COVID-19 has brought a raft of intense new stresses while removing many of the resources people have traditionally used to cope with them. A good number of people have lost their jobs. Some have lost their homes or businesses. Families cooped up together because of stay-at-home legislation are generating even more stress, which may increase the risk of intimate partner violence and child abuse. Disrupted routines and the potential for contracting a life-threatening disease may exacerbate pre-existing problems, such as mental illness or substance abuse. At the same time, physical distancing is endangering mental health as it protects physical health. People in crisis may avoid hospitals, whether for fear of adding to the burden of already overwhelmed facilities or catching the virus. The danger is this could lead to a perfect storm when it comes to the risk of suicide. Remember that if you have any questions, to type them into the Zoom chat box, and our moderator, Dr. Anna, will present them to the speaker. I now pass you over to Dr. Andrew Mohanraj. Thank you.
Thank you, Tom, for that very generous introduction. Can everyone hear me clearly? All good. Okay, that's fantastic. So now really comes, and good evening, everyone, and thank you to the organizers for inviting me here. And it gives me a really great pleasure to be here to deliver this, my address here today, and really with the hope that from now on we are going to see a bigger role as well as greater interaction and collaboration between all mental health professionals in Malaysia to navigate these challenges ahead of us in this rehabilitation and healing process that remains a challenge for all mental health professionals. Now, I personally must navigate through this great IT challenge. So please bear with me. I'm going to click on these various buttons that Julian had advised me to do before I share my screen. So if it's going to take a little bit of time, I seek your indulgence. See, I've got it in one go, so not bad. Yeah. All right, now. Okay, so as was introduced just now, my name is Andrew and I'm here. I wear several hats, but today I'm here in my capacity as the president of the Malaysian Mental Health Association. And I'll touch a little bit on the topic of suicide, but because in this today's August assembly here, we have mental health professionals. I gather that they are mainly mental health professionals or budding mental health professionals, students in the field of hypnotherapy, and perhaps students in other fields in mental health. And therefore, I think it is also good for me to also touch a little bit or dwell a little bit on the give a more contextual perspective of the issue of suicide. It might sound a little bit academic, but nevertheless, I'll try to weave in this context into the topic of discussion today, that is the challenges, the mental health challenges in this era of pandemic, and how we as mental health professionals can live up to that challenge and meet the demands of the new norm. So the outline of my talk today would be very briefly touch on the introduction of what suicide is, give a little bit of perspectives, historical perspectives, talk about the global scenario. Then we'll touch a little bit on what is the understanding of the etiology of suicide. This can be a little bit interesting because I personally do not agree with many of these etiologies that have been postulated. Nevertheless, it's interesting for us to know as students in the field of mental health. Then we'll talk about the biopsychosocial risk factors and what are the protective factors. And these are important because some of our interventions that we are doing during this phase in the rehabilitation and the healing phase really should take into consideration the protective factors. And then we'll talk about what are the stages of suicide, the warning signs of suicide, which we are all familiar with, but I think I should just touch on that as well, because our intervention is also based on that. And we'll also discuss suicide in adolescents, and this is something that is very alarming recently worldwide as well as in Malaysia. And what are the prevention strategies? What happened during the pandemic in terms of psychological decompensation, and what can we as mental health professionals, and particularly in the professionals in the field of hypnotherapy, can do to meet the current needs. And together, let us see what are the immediate challenges ahead. Now, the word suicide itself, comes from the Latin words sui, that's oneself, and sidium is killing, and that is to commit an act with a fatal outcome. And which is deliberately initiated and performed by the person with the knowledge of its outcome. And later we will see really this itself is a little bit of a paradoxical statement here, because a person who commits or attempts suicide actually doesn't quite know what to expect in terms of its outcome. Now, the interesting thing about suicide is it is a very complex phenomenon, and really there is such this non-congruence between the expectations and outcomes, and it's really in terms of the expectations and the outcomes. It is a very, very, what should I say, a gray area. There is a tremendous pressure on the mind, and therefore it blinds its logic and forcing a conclusion of escape. So suicide is really an escape, a conclusion of escape, rather than fully understanding what is the expectation and outcome of it. So in today's terms, I would rather look at it as an escape from tolerating the pain, and rather than actually expecting the real outcome of it. Now, a primary emergency for mental health professionals, and we all know how this suicidal attempt is definitely an emergency, and it should be looked at as a health emergency and a crisis. As we will see in the following points in my presentation today, it is also a major public health problem. Now, as far as a little bit of history on this, in ancient Greece, a person who committed suicide without the approval of the state was denied the honors of a normal burial. And even in ancient Rome, it was said that, in the beginning, suicide was an accepted, method to deal with military defeat. And subsequently, when it was banned, or rather the state did not encourage suicide, it was said it was because of an economic reason, that they couldn't afford too many of these jilted lovers and those who are, facing the ring in the Colosseum, dying intentionally. And the state couldn't afford a funeral for them. So, I mean, these are all anecdotal evidences. We don't know what is real and what is not, but we do know about the Japanese harakiri and the honor associated with harakiri. In the Judaic tradition or the Abrahamic faith, in Islam, suicide is prohibited. And this is also reflected in the prevalence of suicide in many of the predominantly Muslim countries. In Christianity, it's considered a sin. And people who died of suicide were not given a normal burial, in the sense that there was no tombstones in the burial ground. So it was also seen to be a mortal sin, really, ironically, to call it a mortal sin. And only after the movement to secularize Christianity, perhaps things have taken a little bit of twist to that, and it is no longer, people are not ostracized even in death. In India, of course, we know that previously there was this tradition of sati, where women whose husband died were encouraged to sacrifice themselves in the burning the fire of the cremation process. There's some myth associated with mass suicide in Ayodhya after Ram returned to Ayodhya, and many of his followers, or in fact many people in the whole town, committed suicide, a mass suicide. So there is a little bit of a cultural phenomenon as well. In the 19th century in Europe, there was a shift in thinking, which resulted in the thought, in the philosophy that suicide is caused by sinful thoughts, and also caused by insanity and evil spirits. So that also had a bearing on people who survived suicide, who attempted suicide but survived suicide, because they had to bear the brunt of the displeasure of the communities in which they lived in. And sometimes it could also ironically end up in them dying by being, due to witchcraft and things like that, or the thought that they were involved in some sort of witchcraft. So in the global scenario, we have every year more than 800,000 deaths by suicide, an estimated mortality rate of 14.5 per 100,000. And one person dies every 40 seconds. This is what the WHO tells us. Now, the second highest cause of death after road traffic accidents in this particular age group, 15 to 29 years old, globally, is suicide. And there are, in some countries today, literature shows us that suicide has overtaken road traffic accidents as the #1 cause of death in young people. I think that is really, really tragic. 75% of suicides occur in low and middle income countries. And in terms of the total global burden of disease, we know in many countries, the first world countries, they have studies to show that the global burden of disease for depression and suicide is phenomenal. Now, when you look at the DALY, or the disability adjusted life years lost in a person's, a working person's life, the #1 cause worldwide until today remains cardiovascular diseases, which means a person who is a working person but who is unable to come to work because of a disability. The #1 cause for that disability today is cardiovascular diseases, but close to that, in the #2 slot, remains depression. And we know that 90% of cases of suicide has got an underlying depressive condition. So therefore, the global burden of disease due to depression and due to suicide is phenomenal. In the year 2019, a research group called Relate Malaysia did a study on youth suicide, and it was estimated that 350 million ringgit was lost, or was the economic loss due to youth suicide in the year 2019. And they came up with a figure of 676,165 ringgit per life lost. That was the economic loss. So this is phenomenal. At the same year, the government of Malaysia also released statistics saying that in the year 2019, the economic loss due to mental illness in the workplace, and this is mainly depression and anxiety, was 24 million US dollars. That's in the year 2019. And in the year 2030, it is expected to touch $30 billion. So even if you wanted to put it, you want to look at it from the perspective of dollars and cents, suicide remains a major burden of disease, and the economic loss is phenomenal. Now, you look at countries like Australia, the Philippines, Bangladesh, Malaysia, and Lithuania. Now, these countries were selected for representing different areas, different regions in the world. And I would just like you to have a look at this and think in your mind as what would you think would be the suicide rates of these countries? And I'll just as a benchmark, I'll give you a clue. Malaysia's suicide rate is, at least the official rate is said to be 5.5 per 100,000 people. And that is how suicide is calculated, by per 100,000 people. Now, Malaysia is 5.5. So I'd just like you to take a moment to imagine or to speculate as to what would be the rates of these other countries. All right, so I'll go on to the next slide now. So this is the actual rates: 13.2 in Australia, Philippines 3.2. Now, is that a cultural reason? Is that a religious? The fact that Philippines is largely Roman Catholic and that, it is a sin in Catholicism to attempt suicide? I'm not sure. I leave it to your interpretation for that. Sorry. Oh. And in Bangladesh is 5.9. Now that's higher than Malaysia, and Bangladesh has got a very large Muslim population. So I'm not sure how to interpret that. Now, Malaysia is 5.5, but we all know, all Malaysians here are familiar or will probably understand that this 5.5 is really not the real figure. It is grossly underreported. Suicide is grossly underreported in Malaysia, and therefore these figures are probably the real figures would be more than 10 per 100,000. One literature, one journal published in Chennai in India said in a study that the rates in Malaysia, this was 10 years ago, was 13 per 100,000. So what is the reason for this underreporting that results in this official figure of 5.5? Now, there are various reasons that I can think of. One is the fact that, the families would like to keep this all hush-hush in case of suicide, and therefore they plead with the police, plead with the hospital authorities not to indicate in the death certificate that suicide was in any way implicated in this. That is one reason. So there's the sympathy involved in here, and therefore it becomes underreported. Another reason is that in our hospital structure, as far as the forms are concerned or the death certificate, there is only one small column to tell you what was the cause of death. And in that, usually the medical officer who's filling up the form, and probably an overworked medical officer after 48 hours of duty at a stretch, is going to write there that the cause of death is because of asphyxiation or drowning or something like that, giving the physical cause of death rather than the underlying suicide that had caused this. For example, if a person has died of asphyxiation, which is correct, but that could have been brought about by hanging or drowning, and that hanging and drowning is not mentioned in the form, and therefore the real suicide rates are not captured in Malaysia. Lithuania has got 31.9 Now, this forms that East European and Scandinavian and other European countries like Austria, and Switzerland, and which is called the suicide belt, where there are more than 25 per 100,000. Japan is not in this belt, but Japan's rates are also alarmingly high. So a little bit, again, I wouldn't go too much into this because I'm not sure whether I have time. But there are several sociological factors. Durkheim's theory is one who might be of interest to all of us here. He brushed aside all the theories by doctors and psychologists put together, and he dismissed it, the whole psychopathological or psychological explanation. And he said suicide is not a psychological reason for it, but more because of a social disintegration. And he divided it into these 4 categories, where he says, an egoistic suicide is because low social integration, for a very self-centered person who felt that he has no place in society and therefore he destroys himself. Whereas altruism or altruistic suicide is the opposite, where there is too much of integration into society and the expectations are too high in order to integrate into the demands of society. And he gives Sati, then Sati is an example of altruistic suicide. Anomic suicide is when there's breakdown of social equilibrium, or the situation where you cannot cope with a particular situation. For example, somebody falls into bankruptcy suddenly, or even gets a lottery, wins a lottery and is unable to fathom how he's going to use the money. So there's a great deal of disturbance and social inequilibrium, and which results in suicide. And fatalistic suicide is in a very regulated society, over-regulated society. For example, a barren wife who commits suicide, or a slave or a servant who commits suicide because of earning the displeasure of the master and things like that. Psychological factors, I will not go too much into it, except that to mention that some of the interesting theories, psychological theories by Freud and Menninger, where Freud said it is related to these 2 concepts of mourning and melancholia, while they are both, mourning is said to be normal, grieving process towards a loss of something that is identified. Melancholia is not, it's the opposite, where it is a pathological grieving of a loss of something that cannot be identified, and this occurs in the subconscious mind. That was Freud's etiology for this. And Menninger speaks about introverted homicide, or anger towards another person that it's turned inward. And also called it retroflex murder. Now, as far as the biological factors are concerned, I will not again go too much into this, but we know that the serotonergic system is implicated in this, in the sense that the reuptake of serotonin is not being sufficient to ensure that the sufficient level of serotonin in the system, and therefore depression results, and suicide can result as a result of depression being there. So those are the biological factors, and that is the reason why they've also made medications like antidepressants, the SSRIs, or selective serotonin reuptake inhibitors, based on this theory. And then, of course, there's a stress diathesis model, which says that people, there's an interaction of different biopsychosocial stressors that results in breakdown of the system. And this is also the basis of where the intervention, to say that the intervention for depression and potential suicide should be multifaceted. It cannot have one formula that works for all. And there's all sorts of other implications of, theories of suicide associated with low cholesterol. I don't want to frighten anyone with this particular statement here, but these are all anecdotal studies. Genetic factors have been implicated. 4 genes have been identified. Again, it's very anecdotal. So we are not absolutely sure whether there is a gene for suicide. We will just for academic purpose know about these, that's all. And then we know about these risk factors, Again, the biological risk factors, we know people with pre-existing mental conditions like depression, schizophrenia, addiction, past history of suicide, and we know this dysregulated serotonin syndrome or system forms a major biological risk factor. And if you look at the social factors, again, we have seen clearly here with early parental loss, isolation, unemployment, and acute life events like in the pandemic as a result of the COVID also is a risk factor. And while demographically we know it is traditionally the older male who is more prone towards completing suicide, nevertheless, we seem to see more and more adolescents in this, in this demography as well. And therefore, it is challenging some of our commonly held beliefs of the particular profile of a person who attempts suicide. Now, we know that in stages of suicide, from the ideation stage to threatening or talking about suicide, and then to the attempt stage, there are interventions that can be done. And the ideal intervention would be at the small window period between ideation and threatening. Some of the interventions that I shall speak about later would be targeting this particular window period. Now, the warning signs of suicide, this is something that we all know. So I will not go into it too much, except to say that this textbook warning signs that I've put up here today, with the exception of obtaining a lethal weapon, the rest of it was seen and documented by service providers after the COVID. And we see this almost textbook kind of warning signs that have been mentioned by people who are close to those who had attempted suicide, and also noted by some of in our helplines throughout the country. And verbal warning signs that, again, we read about this as mental health practitioners. We are told about this. I'm sure textbooks mention this repeatedly. I can't go on anymore. I wish I was never born. People would be better off if I were dead, and things like that. Now, we saw all these classical signs, even though they were not exactly verbal most of the time, but because today the social media plays such a big role in our lives, it almost as, some people use it as a diary to express their thoughts. The moment they wake up in the morning, they have to, take a picture of their coffee, and then they say how they feel about themselves this morning and what they expect the day and things like that. In a way, that is also good, because many lives were actually saved because friends and family read the social media posts of those who were suicidal. And these were the verbal warning signs that were there. So we know, again, these protective factors of staying connected to family and having community support, and being able to solve our problems, breaking down our problems into smaller problems and solving them one by one. Some people have this ability to do that, and this is our protective factor. And we are also protected by our own cultural and religious beliefs that in some cases discourage suicide and support self-preservation. Even if you didn't subscribe to any particular religious beliefs, there are some communities that are very, very strong on self-preservation. And restricted access to means of suicide, this great deal of progress has been made in our country. In this is particularly with regards to pesticide and other forms of methods of attempting suicide. We do not have the problem of firearms in this country like the United States of America. So that is something that's very good for us. And then, of course, accessibility to equal quality mental health support. Some work needs to be done in this area, and I shall talk about it later. Now, I've got another 10 minutes, so let me go through the remaining of the slides a bit more quickly. So, management of clinical practice, of course, we all know as mental health practitioners, we need to make an assessment. We use different scales for this, for suicide. Some people use a SAT scale, SAT person scale, which is very, very specific in nature, but not very sensitive. in terms of the testing. We need to treat the underlying psychiatric disorders. Some people jump into the biological intervention and pump everybody with antidepressants. But as we know just now, as I've mentioned, some of the theories of the basis of depression and suicide dictates that it can be multifactorial, and the interaction of different biopsychosocial factors, which only means that there cannot be one formula to treat underlying psychiatric disorders that can result in suicide. So we need to also look at various psychological interventions, CBT, hypnotherapy, and of course, depending on the situation, family therapy, group therapy, and also not to mention or not to forget social intervention. Now, suicide in adolescents, as I had mentioned earlier, is also an emerging threat. We see the ratio is no longer subscribing to the traditional thoughts, or what we have been told about the more males. Internationally it's 1.3 to 1, but we see the male and female ratio is equal here, and there's also implicated violent and abusive environment. And this group is seen to be a highly vulnerable group now in Malaysia. What are the causes? The identified causes are mental illness, underlying mental illness, particularly in males, where serious mental illness like schizophrenia, at the onset of it is rather early, 17, 18 years old, rather than in females, which is much later. And therefore, we know of many cases of people with severe mental illness resorting to suicide. We also know that 5% of people with chronic mental illness like schizophrenia, worldwide statistics tell us that 5% will die of suicide. So school difficulties have been implicated, separation, rejection, and all this has been exacerbated by the movement restriction during the pandemic. And also not just movement restriction, but also not being able to attend class, the normal study environment. And some families do not have the luxury of staying in a big unit, and particularly in the lower socioeconomic groups, and this can result in a lot of physical and sexual abuse, and not to mention bullying, but online bullying, that seems to be the norm as well these days. So bullying has been taken out from the school playground to the online platform. All right, so as far as population strategies for prevention is concerned, now, clearly, we have, as the Malaysian Mental Health Association and other organizations, civil society organization in Malaysia, working together with the government and Ministry of Health, Ministry of Community Development, have come up with some strategies for public awareness, creating more awareness on, or rather mainstreaming the conversation on mental health and suicide. There's a lot of effort that has gone into it recently. Malaysian Mental Health Association also has a program called A Conversation on Suicide, which is really a 2-hour training on suicide prevention that is given free. And now, for now, it is still being done virtually online, but we hope to start on it, doing the sort of a physical training, and it's done free, and this is targeted at community leaders, management committees of high-rise buildings, and public housing, for them to understand what suicide is all about and how to reach out to a person whom they suspect to have suicidal tendency. So we have also come up with guidelines for the media on how to report suicide, how not to sensationalize suicide, how not to put pictures of that particular scene, the suicide scene, and things like that, to prevent copycat suicide. There's formulation and packaging and sale of pesticides. As I've mentioned earlier, there's a great deal of progress has been made in this country that prevents the sale of pesticides without without a real reason for the purchase, pesticides, use of pesticides used to be the #1 cause of death in our country not too long ago, but that has changed. There's regulation of over-the-counter medication as well to prevent overdose. Legislation, interestingly, ladies and gentlemen, I must say that in the last couple of weeks, a great deal of progress has been made in terms of legislation. Section 309 of the the Penal Code has been, or rather there is work underway to suggest to Parliament, to debate in Parliament that it should be repealed, and there's every indication that that will happen. So that's good news now. So the old thinking that you need legislation to frighten people not to attempt suicide somehow, fortunately, that sort of thinking is outdated and it is no longer seen as prevention. In fact, with this repeal of this particular legislation, hopefully that will happen soon, then we will probably see more people who are in distress reaching out for help rather than otherwise. Alcohol-related policies also needs to be reviewed, and that has clearly been shown in many countries in the world that because alcoholism is strongly related to suicide, apart from other substance of abuse, there has to be policies related to the sale of alcohol, not necessarily an absolute ban on the sale of alcohol, as some of our very imaginative politicians tend to think. Now, in other population strategies involve crisis intervention, counseling, and hotlines. Now, this has been overwhelmed recently in our country. All the NGOs providing hotlines have found that these have been overwhelmed, and also as a result of not just in terms of catering to calls to hotlines, but also the whole system has been overwhelmed by the fact that counseling services and other form of psychological intervention has been moved to the virtual platform. And therefore, there has been a strain on human capital to cater to the needs or to provide services in terms of crisis intervention, counseling, and hotlines. And then, of course, there are training programs for lay counselors. One of it that I mentioned just now was the training on suicide prevention. The MMHA also has something called mental health first aid, and we are rolling out that program as well for those in the corporate sector, as well as community leaders in the universities, in schools as well, for them to understand a little bit more about mental health and how to detect psychological decompensation as early as possible and offer appropriate intervention and referral. There is a need to redesign the curriculum for medical and nursing students because currently medical and nursing students have very little exposure to psychiatry or mental health. In fact, there's some improvement now with greater exposure in the clinical settings. Previously, it was only in the mental hospital, and when a doctor or a nurse graduates, they have a very poor opinion of mental health and mental health facilities. And that resulted in very few people choosing to be psychiatrists or mental health professionals, or choosing a specialization in among the nursing students to take up post-basic qualifications in psychiatry. There's also intervention programs for high school. I think a lot of work that needs to be done in this area, given the fact that there's been a great distress among the adolescents, and we see adolescent suicides also increasing in numbers. And there's a need to place the placement of personnel in high-risk settings. What are these high-risk settings? Obviously, in settings where we come into contact with people with psychiatric disorders, for example, in schizophrenia or chronic depression or bipolar disorder as well, to help in the treatment and prevention of suicide. Elderly care support facilities as well. High-risk occupational groups where, for example, a policeman, there has to be some further policies for a policeman or an army personnel to be, for his firearm to be, kept in a safe place before he goes back home. Things like that has to be looked into. I'll give you one example just very quickly before I finish, of a case recently in Klang, Selangor, where this lady who was fairly high, well functioning, she had chronic schizophrenia. She used to go to the hospital every month, get her shots, get her depot injections, and she was doing pretty well. But because of the movement disorder, what do you call that, movement order, restricted movement order during the pandemic, she couldn't go to see her service provider. She skipped on some of the medications, the depot injections. The family could not, could not supervise her compliance of medications, and therefore she relapsed. She became, she relapsed so badly that she wanted to jump off her balcony. And fortunately, intervention was done on time, and she was taken to the hospital. So clearly, there's a case of somebody who's high functioning, living alone, managing quite well, but because of other factors during the pandemic that has resulted in the exacerbation of her symptoms and her relapse, right? So, and we see this happening, psychological decompensation during the pandemic. We know of cases where there's been increase in stress, anxiety, and depression, and all this is based on records, on helpline records and the hospital records, both the private hospital and the public hospitals as well. So an increase in the use of alcohol and substance, and as I mentioned earlier, services were being overwhelmed. And the good thing about it is that also the silver lining behind all this is that there was an increased awareness of mental health issues. There's increased political attention to mental health. The recent budget has given for community intervention alone 70 million ringgit. So there is greater political attention, and not just in terms of allocation of, monetary allocation, but also a change in the mindset of the political leadership that something must be done as far as mental health interventions are concerned. What has also happened is there's a greater awareness on the utilization of various modalities of treatment, including hypnotherapy. People are no longer saying that if somebody has got psychological decompensation, the next thing to do is to give them antipsychotics, antidepressants, or mood stabilizers. No, people are looking at various modalities of treatment, including hypnotherapy. And the fact that, hypnotherapy has proven itself on, there's enough very strong evidence for the use of hypnotherapy in the management of chronic pain, of headache, in chemotherapy, as an adjunct treatment for chemotherapy, to prepare clients for chemotherapy, and as well as to tolerate the pain of chemotherapy and the side effects of chemotherapy. This all has been proven. But now I think the role of hypnotherapy becomes even more pertinent in this particular phase, this very difficult, challenging period that the country is undergoing, and in this healing phase where we need to apply the skills available to treat and to make the necessary intervention in depression and suicidal ideation. Hypnotherapy has been very successfully used to identify past trauma and in the treatment of PTSD. We also are anticipating a high number of cases of PTSD-like symptoms among our frontliners, mainly the medical frontliners who may be asymptomatic at this stage, but soon I think we are going to see, the lingering effects of the pandemic rearing its ugly head in the form of PTSD. And that is why I think hypnotherapy would also be, it's a useful modality to be considered. And for sure, in coping with stress and anxiety, treatment of phobias, and we see all this happening during the period of the pandemic. More and more people are presenting with symptoms of phobias, various phobias, and also the treatment of insomnia and smoking and overeating. Hypnotherapy has been successfully used in this, and we also see this becoming an issue now, particularly when there was a movement restriction. and people had to stay home. So they started coping with their challenges by increasing in their use of nicotine and coffee and alcohol, overeating, and also had insomnia. So things like this, I think, is something that I think practitioners of hypnotherapy should rise to the challenge of these and meet the needs of the population. Ahead of us, we will continue to see the lingering effects of psychological decompensation, as I mentioned just now, PTSD among frontliners. We continue to tackle stigma and poor awareness on suicide. Insurance coverage is barely started now. 3 companies have started covering, providing coverage for out-of-pocket private insurance expenditure. We are hoping to do more work in this area. Certainly human capital continues to be a big challenge. We do not have enough mental health professionals in this country, but while that is the case, I think we should also, all of us as mental health professionals must come together here and understand that when we come together to meet the challenges of society now, together it will also result in a little bit less burden in the human capital that is currently there in the public sector. It might result in a little bit of task shifting, which will enable more people with serious mental problems to access services at the public sector. And therefore, it's also good to move away from the purely biological approach in intervention. I've mentioned our successes in legislation, but at the same time, as far as the private sector or the workplace is concerned, we still do not have enough workplace policies to look after or to ensure the rights of persons with chronic mental illness is looked after, or even to ensure that there is some form of normalization in the conversation of mental health issues. So these are structural changes that needs to be done within the workplace. We are hoping to make some progress in that. And finally, ladies and gentlemen, thank you very much for giving me this opportunity. I'd really like all of us mental health professionals here to take a more holistic and complementary approach in this healing process that we are going to face as a nation. Thank you very much for this opportunity. I'd like to say a big thank you to Dr. Sheila Menon and her team for organizing this international conference. Despite all these challenges, ideally we would be sitting in a nice conference hall and having our coffee break and chatting with each other, and getting to know each other more. Unfortunately, that is not possible under the circumstances, but I must say you have done a great job. Thank you very much.
Thank you, Dr. Andrew. It was certainly a great overview of a very important topic. We do have some comments and questions, but in view of time, we will be collecting these questions and emailing them to you, Dr. Andrew, and we will get the responses back to the participants. So if the participants have any other questions for Dr. Andrew, you can still ask them in the chat box right up to the end of the day. We will be compiling the questions and sending them out. Once again, thank you so much, Dr. Andrew, and it's back to you, Tom.